Hey guys, it's Sai, and welcome to Ace Podcast Nation, our latest show on mental health, and our third show focused on primarily on ADHD, but we'll talk some other subjects. Here at Ace Podcast Nation, we've got podcasts, interviews, content on various subjects, including mental health, football, films, TV, music, conspiracy theories, you name it, we talk about it. You can find us on Facebook under Ace Podcast Nation, same on YouTube, as well as Twitter is at AceCast_Nation, where you can keep up to date on our different series and upcoming content. So you can find all our previous shows on YouTube. We've done 2 previous shows on ADHD. One was with Jacob, who was a mental health support worker and also has ADHD. So we discussed what it was like living day to day with him. I spoke to Phil Brown, a football journalist, about grief and depression. And I also recently with Chantal Branston from ADHD Positive about living with children with ADHD. So today, I'm very happy to welcome a mental health consultant doctor who is heavily involved in trying to raise awareness and education when it comes to ADHD. He's the clinical director of Mental Health and Wellbeing Limited. I'm very grateful to welcome Dr. Wasi Mohamad to today's show. Welcome, Doctor.
Thank you so much, Simon. Thank you for having me.
Oh, that's absolutely no worries at all. I'm just very grateful that you're able to spare me the time. Okay. So, obviously, ADHD is a complex subject. So what I wanted to start with is perhaps for people who perhaps were like me before my son was diagnosed. I think I mentioned to you before, I was very ignorant to what ADHD was. I sort of thought it was down to discipline or things like that, which I'm sure is quite a common thing. But would you be able to just explain from a clinical point of view, what is ADHD? What is ADHD?
Well, I mean, ADHD is a term which is a short form for a condition called attention deficit hyperactivity disorder. And it is considered as a neurodevelopmental condition. So, it basically means that more often than not, somebody with that condition might have it from a very young age. So there will be some kind of, changes in the brain potentially, which could be contributing towards having that condition. So it is one of those sort of quite probably one of the commonest neurodevelopmental condition in psychiatry or child psychiatry, and autism is also one of them. And sometimes autism and ADHD can go hand in hand together as well. So you can see people with ADHD. Some 30% of them might also have some features of autistic spectrum condition. So that's what it is really. So I think normally the traits of the condition, either from behavioral point of view or from cognitive point of view, will be present from sort of young age really, and quite often it can enter into your adulthood as well. So that's what, in a nutshell, ADHD stands for really.
I think one of the things which interests me actually is when I was younger, which obviously I'm 37 now, so you're talking like 25 years ago, if you had sort of children who were struggling in their lessons or they were misbehaving, very often those children were just put in the bottom set and kind of left to it and didn't get some of the support which, like, I know my son gets now, and that's helped him to achieve a sort of the level where he's capable of ability wise. But I do wonder if he was in school during the time I was in school, even though he's quite, he's intelligent, he's in the top sets of everything. I think he wouldn't have had the understanding and the support that he has to enable him to hit his actual ability, because before he was diagnosed, he was struggling with concentration. He was shouting out, maybe being a bit inappropriate or messing about. And I think it's a very, don't get me wrong, it's a fantastically positive difference. But I wonder how many children from when I was in school who didn't get that support, how much it affected their school life.
I think it's
do you think? Go on.
It's a very valid.
I was just going to say, yeah. I think it's a big change, isn't it? And I think, do you see that like on a day-to-day basis? Would you say that you can see the opinions and support changing for the better?
Absolutely, absolutely. I mean, I think it's a very valid point you're raising here, because my own work is primarily at the moment, because we're a small sort of a private regulated company. We are regulated by Care Quality Commission, and the local services in Shropshire have commissioned the adult ADHD work. So it's about who are people above the age of 18 to because I think there was a huge gap when children were coming out at the age of 18, and some of them had the diagnosis, but then nobody was there to look after them. And again, so we started supporting those people first, and gradually more and more new referrals, which we are picking up now, are people perhaps of your age group, maybe somebody even older, who, because there's a bit more understanding of the condition, or they might have had some of their children or other relatives who might have had that condition, and they might have seen that maybe I've got some of those traits as well, and whether I've had these difficulties from a young age, and they often reflect on that, and they come out forward. So I mean, I was reading a very interesting statistic somewhere, and I think in 1990, which is, it doesn't seem that long ago, which is probably about 9 years ago, there were only 40 prescriptions of in UK of methylphenidate. So can you imagine? So we've come a long way from that, and I think the age group which I suppose you are referring to yourself and your colleagues, maybe from that era where perhaps there wasn't that awareness. I think there's still a lot needs to be done even now, but clearly at that point, probably in my view, a lot of people were not getting the right help. What we are now picking up a lot of, sometimes we pick up some of those patients, and then we obviously take a detailed history of their earlier experiences, and a lot of those traits which you're describing were present from a young age, and they would often bring their memories of school and report cards, and you'd pick up anything, really. If they were, in the school at this current day and age, they might have had a better chance of being picked up for that condition, and might have had the treatment, which actually has one of the best results in the field of medicine, really.
Yeah, I think I gotta say, like, I could, speaking from a personal point of view, seeing the difference in my son before he was diagnosed and afterwards, and then once he was allowed to get the support, because I don't know if it's in the whole of Wales, but it's certainly in his school, he wasn't able to get certain aspects of support until he had an official diagnosis, which was quite a frustrating period for us, because the school sort of knew he had ADHD. We knew he had ADHD, but it was just a case of waiting for the process to finish. And once he got that support, it was like, it's been like night and day. So he had a very difficult year 7, and then year 8 and year 9, he's in the top sets of everything, and he's generally not having too many problems. When I spoke with Chantal the other day, she was describing some of her experiences. She did say that she'd had quite a lot of trouble trying to get her children the right support. So, like you say, there's definitely still work to be done on, when you compare it to 20 years ago, it's a lot better. So just sticking on the sort of what is ADHD type of area for a minute, what's the main difference between ADD and ADHD?
Okay, well, I mean, these are sort of slightly academic and diagnostic terms which can get slightly muddled up. So I think the ADHD is a sort of overriding umbrella term which we use, and I think there are two main diagnostic manuals we refer to. One of them is a DSM-5, which is from American classification system, but it is recognized worldwide. The other one is ICD-10, which is World Health Organization, organized sort of diagnostic manual. So the term ADHD is overall umbrella-wise, used for these conditions. If you look at the sort of DSM criteria, there might be when the overall diagnosis will be ADHD, but we could say that somebody predominantly might have ADHD with more inattentive symptoms, or some people might have more hyperactive or impulsive symptoms, and quite often both those symptoms are present as well. So I think that is just a subtle difference, but it's so loosely used. But I think
Yeah.
if I was to give a diagnosis to someone, I would say you've got symptoms of ADHD, but predominantly inattentive type, or predominantly hyperactive type, or mixed. So that is probably the best
Yeah,
way of
I
explaining
can
it.
see what you mean.
Mhm.
Um, if so, if a parent was watching this, um, what symptoms or traits do you think they could help or look out for to help them distinguish between like a boisterous child and a child with ADHD?
Okay, so I think one of the key things would be that the behavior, if you stick to the behavior element of the condition, will probably be present not only in school but also at home. So it would be in a wider context. It's not just going to be situation specific. So it could be that in classroom the child might struggle to focus or concentrate in class for too long, very easily get distracted. Often you might think that somebody has dropped a pencil, but instead of focusing on the lecture, you'll be looking at a pencil for a long period of time, or if something is going past the window, you might easily catch their attention and distract, and they might then go back to the topic, but they might have missed out a few minutes there. So they are more
Yeah,
easily distracted. And often the people could zone out, so they might just be some of the people, children, maybe sitting, and I think often in girls as well, we might notice that they are daydreaming, or their mind is wandering and not able to kind of stay on the focus. And that also causes them difficulties in their academic performance. Not that they're not bright, they can perform very well, but often putting the sort of thoughts and cognitions into exam results can be
yeah,
quite a difficult process. So that's inattentiveness can be a major problem. Often people can also get very impulsive and restless. So there are naturally, you might find them to be a bit more energetic, hyperactive. They find it hard to stand in a queue for too long. They might be very impatient. They might sort of blurt things out sometimes more. They'll be fidgety. They'll could easily get, and they might be great into sports because they have got energy, but you must notice them fidgeting, squirming, biting their nails. That kind of hyperactivity or restlessness could be a feature. Then emotionally, sometimes they can be quite, up and down a little bit. Easily somebody says the wrong thing, they can might react more, easily get upset or easily get angry. So they often do not have that sort of 5 minute or a few seconds of time to sort of stop, having a think before the actions. They might do something quite impulsively, and that might get them into trouble
yeah,
in the classroom. So those are the sort of things. And again, in home, what you might notice that they're easily bored. They're always seeking for some stimulation because their mind is wandering at a fast pace there. And so sitting in a dining table having a meal with the family could be quite difficult for them. They might be pacing up and down, and so those are the sort of features which will be quite prevalent, not only in school but at home. And as they go older, sometimes that can get them into difficulties because they start to mix up with the crowd where they get this, dopamine kind of satisfaction, and get into drugs or conduct issues, and that's where we start to see more kind of severe or more difficult aspects of behavior, which gets them into trouble potentially with the law, or using drugs or substances sometimes. So that's also quite common with people with ADHD who are not getting the sort of right help.
yeah, yeah. I can I can certainly relate to the like the impulsivity. My son would quite often you could almost see him saying stuff without thinking it through first. So it was
Mm-hmm.
almost the way we used to describe it when talking to my wife was he hasn't got a filter.
No.
Whereas some people, they might think about where they are and what they're saying. he would sometimes just say it.
Right. Yeah.
And even now, I mean, even though he's 14 now and he's doing very well, he still can react quite emotionally if his younger brothers winded him up, particularly sort of later in the day. It can be, it's like it just happens rather than him thinking about, reacting or thinking about what he's going to do. So I can certainly relate to that. Even, like I say, even now with him, he's having treatment and he's doing very well in school.
Yeah, the traits might still happen from time to time, and yeah.
Yeah, and I think like he takes some medication, he takes Zagatin at the moment, and that's lasting a bit longer. But I think you can tell when it gets to sort of 5-6 o'clock in the evening, he's very much more emotional, and he's a bit more sort of fidgety, and just generally you can just generally see a big difference in him.
Yeah.
And first thing in the morning as well, when he first gets up, is my least favorite part of the day, is trying to get everyone out to school, because this can be a bit of a battle sometimes. But
that's right. Yes.
So everything I've read, come across, obviously, since he was diagnosed, I sort of read up as much as I could, really. But everything I read or came across said that diagnosing ADHD in girls is a lot more difficult than boys. First of all, is that true? And secondly, why is that, if that's the case?
I think it's a difficult question to answer, because sometimes even we can't generalize it to the boys or girls. Sometimes some boys can be difficult to diagnose as well, because you would normally stereotype in your mind about an ADHD boy to be quite hyperactive and boisterous, or getting into trouble. But there are some boys, particularly with some autistic traits, who might be actually sitting very quietly in the classroom, and they may not be communicating much, but they'll be zoning out and they'll be in their own world. So they might have a lot of inattentive symptoms, but because their behavior is not so bad or difficult, they don't get picked up, because usually teachers and everybody will start to worry about the people who are causing them some issues. It's possible, I think, that girls, some of them could be like those, and I think girls often could zone out a bit more, so they might come across as more emotional. But maybe that's why perhaps sometimes these things can be considered as more sort of anxiety or depression or anything else. But often when we dig deep and have a careful analysis, sometimes ADHD traits are also present, and often get missed, sometimes even by specialists. I've seen a few girls who come to us from other areas where they were being treated for anxiety and depression with antidepressants and other things, but actually digging deep, I think we've picked up that there were a lot of issues with the ADHD as well, and the treatments are so different, and so they perhaps were not getting the kind of right treatment, really. So it's possible, but I wouldn't generalize it completely, because I think there are some boys as well who could who may not get picked up as well.
Yeah, and I think one of the things is, ADHD, it's not like a broken arm where you can do an X-ray and you can see the arm's broken, this is the treatment. It can manifest in different children in different ways. And one of the things I've been keen to do when I was speaking to parents of children with ADHD is try and raise awareness by showing people that what works for my son might not work for Chantal's two kids, or someone over here or over here, and what my son struggles with, and his symptoms and traits which manifest either now or when he was younger, they might be completely different in someone else.
Absolutely. So that there are obviously going to be some similarities, but again, we are dealing with individuals who might have their own personalities, their environment, and the way they brought up, or so there will be obviously some subtle differences there, and cultural differences as well. So I think it's probably not easy to sort of just categorize them and stereotype them into just one or
Yeah.
two particular categories. So they will have their own individual subtle variations with the condition, just like any other condition. For example, bipolar or anything else. Not everybody gets exactly the same kind of symptoms, but they have their own variations to it, and responses to the treatment can depend, and that's why we tailor treatment very much based on an individual. What medication works for one may not work for the other, or sometimes we have to mix and match, so we give them a longer acting, and when some people are perhaps metabolizing them quickly and they're noticing that at 3 or 4 o'clock they're just not able to, they're zoning out there again, so we may have to give them a short acting top up for
Yeah,
4 hours
of course,
after
yeah.
that. So it is very much based on a very much individual. The treatment is tailored individually, really. So to sort of tackle those sort of subtle differences in a person.
Yeah. I think that's certainly, like, again, I can completely relate to that. There's part of my son's treatment is he started on a low dosage and he sort of moved up until they found the right dosage for him. But then we were finding that it was wearing off by the sort of last lesson of school. So he was having a bit of problem in that lesson. So they changed it to like a longer acting one. Sorry, a longer acting one, which now lasts that bit longer.
Yeah.
Because he himself didn't really like the top up one where we had before. We used to take like a top up for the evenings. He plays a lot of football and sport, but he didn't like it because he would sort of struggle to then settle after football and sort of get to sleep.
Oh.
And it's almost, I suppose it's the same with any treatment, but certainly any mental health treatment is there's no one way for everyone. It's not like sort of antibiotics or something like that. It's with any mental health illness or disorder, it's going to be sort of mixing and matching treatments and medication if that's necessary, and then finding what works for the individual. So yeah, I don't envy you in terms of trying to find the right, find the symptoms, diagnose it, and then find the right care and treatment for patients, because it's particularly with mental health, it's like a minefield of various things it can be, and then you're trying to find the right treatment.
Yeah, and I think sometimes we work in the way I would like to work, and I'm sure most services are probably doing the same, is to work in a partnership with the patient as well as the carers, and have a very open, transparent kind of discussion, have that rapport and trust, so that we could work together, because as clinicians we are only going to be guided by the sort of feedback on the treatment which we are giving, and for us to sort of adjust the treatment and fine tune it, perhaps it needs a lot of and there are various sort of tools we use, and feedback forms and rating scales, and that can also give us some objective evidence of what symptoms are perhaps targeted better, and maybe where we need to still focus on attention. And again, medication is just one aspect, and perhaps a very important aspect of the treatment, but there are other treatments in terms of psychological help, or coaching skill training, or life skill trainings, and behavioral strategies, and working with families in terms of family therapy. There is different aspects which can be brought into the treatment as well. I think the resources are stretched in NHS, as you would imagine, and not everybody is able to afford private therapies and stuff, but I think in an ideal world that a very kind of holistic approach would need to be tailored for that family, and for in supporting the child.
Yeah, definitely. And so for parents who say have been recently diagnosed with ADHD, or are in the process, going through the testing process, and it's new to them, what would be like the best advice you can give them to help both the parents or the carers and the child deal with ADHD daily, in terms of now they've got a diagnosis? What advice would you give them in terms of managing it?
I think again, the key advice would be, first of all, sort of giving them education about the condition, taking the sort of blame and shame away from it, and stigma away from it, that it's not that you're a bad boy or you're a bad girl or you're difficult. Sometimes the brain is wired up slightly differently, and helping them to understand how the ADHD is not all negative. I mean, I see people who are, because of the very nature of ADHD, might be quite successful in some other areas. So I think just trying to find their strengths, that find they might have some weaknesses or difficulties in one area, but there are also some strengths. It brings a lot of strengths. I mean, I'm sure there are celebrities and business people. I've treated doctors and dentists who've got this condition, and they're very bright. So helping them to understand the condition, giving them the relevant evidence-based information, relevant websites. Also, I think helping the school and teachers about their condition, so that they can tailor the support for them in the classrooms. And maybe it could be that for some people, having 2 or 3 doses of medication works better, so they might have to go into the lunchtime and have their medication. So supervising that element. So again, for an individual, I think various things will happen. Also, I think sticking to sort of structures, routines, putting some organizations around it. Could be that morning, as you were saying, is not a very good time for your son. So maybe preparing the school bag at night, maybe taking a shower at night, so that in the morning, it saves them half an hour during the time when they're sort of getting into it. So sometimes very simple strategies and guidance can also make a lot of difference. So, but yeah, again, I think definitely initially in finding the right clinical support and also pharmacological treatment is actually quite important in ADHD, because it can be a game changer, for a lot of people. Yeah.
Oh yeah, definitely. Like I mentioned, the difference in between before he had the support and after was like night and day. And I think from a personal point of view, my advice to anyone is always get that support in school. Make sure the school understand the difficulties that your child is having, and tell them he needs help with this, that, whatever it needs to be. And I would, I've been very lucky. We've been very lucky. The school's been very receptive to that. I'm sure there's other schools or schools around which aren't, but I think getting that school support and help is vital, especially in that early stage of they start taking medication and you're still on a low dosage, or you're trying to work out what's best. It's very important to get that balance right, both in school and have a good partnership, as you just said, with the consultant or with the mental health team, or whoever you're with, children's services. It's vital, that especially in that early stage. My son was very emotional when he found out that he had an official diagnosis. Even though he knew before, he got quite upset. He said things like, I just want to be normal. So we were very aware that at that early stage, even though he knew it was coming, it hit him quite hard. So he was even more emotional than normal. So obviously we had to give him the support and talk to him about that. It wasn't a long period of feeling like that.
Yeah, but
certainly
I think comes with it, and accepting it, and obviously it's quite an emotional time for a lot of children, and even for adults, because I sometimes most of my work currently, for the commissioned aspect of the work we do, is with adults, and I think we've had a lot of emotional consultations when the diagnosis is shared. Because I think for adults sometimes also it's quite hard to look back and think that perhaps they've been dealing with it for 35 years, and maybe there's a little bit of feeling that perhaps if they had the right help before, their life could have turned around in a different way or different direction. So I think that can be quite a difficult process for some people. And so I think keeping them involved in hope, and having the sort of compassion from the professional team is working with the parents, school. That's the key, really. It's not just a consultant who's got a magic answer. I think it's a teamwork here, really. Yeah.
Absolutely, yeah.
Mm.
So one thing I wanted to ask you, before we go into sort of more technical or current issues around ADHD, was in terms of the history of ADHD, when were the first sort of cases of ADHD diagnosed?
I'm not the best historian, but I think from what I've read, I think there have been some mention, even in the sort of 18th century or early 19th century, about some behavioral disorders but I think it's probably early 1900s where some cases were picked up, and amphetamine type treatments were accidentally used for some of the children for some neurological condition or headaches or something. But actually they've found out that the focus and concentration and ability to sort of maintain attention and behavior change with that. And I think that since then, I think there's been a little bit of a new, it's evolved over the years.
Yeah, of course, yeah.
Having said that, I mean, Ritalin or methylphenidate has been available since 1950s, so it's still very widely used. So yeah, and it's still often the first line treatment for children.
Yeah.
Mm.
So another thing, following on from that, really, is do you think anything has contributed to the rise in ADHD diagnoses and cases? Since those, obviously years ago there wasn't many, and now there's more. Do you think that's down to just advancement in medical science, or is it down to diets and medications and TV and things like that changing over time? The reason I ask that is because I believe that it's just more knowledge and advancement in sort of medical knowledge, but obviously there is people out there who think that ADHD is not a real thing, and they just think it's diet or environment or TV and additives, things like that.
Yeah, and I think it's my own view is that perhaps that over the course of the last sort of 15, 20 years, there's been a little bit more awareness of this condition. So perhaps it's been better identified, and that could be probably one of the reasons why we are seeing an increased prevalence of this disorder. I still believe that even now it's underdiagnosed.
Yeah.
I think the prevalence, if you look at it from various worldwide researches and in epidemiology and prevalences, I think we should be having a prevalence of around 5% in children and between 3 to 4% in adults. And I don't think we are picking up that much now. So it is very much a neurobiological condition, often is a strong genetic link. So you might see that there is usually somebody in the family, either a brother or a father or a mom, or if not in the first degree relatives, somebody in the second degree relatives in terms of uncles, or there will be some links with neurodevelopmental conditions like ADHD or potentially even autism. So and I think careful history taking of family and developmental history becomes, also now we've got quite a more and more quite high scientific researches in terms of your brain scans and what the medications do to the various receptors. They are beginning to emerge as well. And I think they do correlate to the effects of the medication and the responses. So I think we are fairly convinced that it's just a lot more than just somebody watching too much TV or having chocolate or coffee or Coke. It could be that those things contribute more in somebody who has a vulnerability, and those brings out the symptoms even more. But I would personally think that, and I think from what the views are, that there is a neurobiological change happening in the brain, which is contributing to that more.
Yeah, I completely agree. And like I say, the reason I slipped that question in is because we come across, I've come across a lot of people who are ignorant to it, just like I was before my son was diagnosed.
And unfortunately, we still have to. We've still got a way to go, because even in the medical fraternity, I think we come across those sort of challenges. It is a little bit of a subspecialty dealing with neurodiverse and neurodevelopmental conditions. I mean, I've had some battles with some GPs who've refused to give the medications because they were advising on keto diet or something like that. And I was saying, this isn't really. It might be helpful in some aspects, but really that's not going to treat the ADHD.
Yeah.
And so we still have to sometimes educate them and give them the current NICE has done very good work, because the guidelines from National Institute of Clinical Excellence are very clear about the usage of medication and psychological approaches and other approaches. It's very stepwise, clearly mentioned, and I often refer to that to these people, that this is the guidelines, this is the evidence we've got, so we need to kind of carry on and work with those, really.
Yes, I think, and one thing which surprises me actually is obviously where I've been speaking to people for the podcast, and I've been speaking to people about ADHD, is it surprised me how many adults I came across who've been recently diagnosed as adults. And then a lot of them seem to be saying it all suddenly seemed to fit together after they got their diagnosis, as if everything had not quite felt right throughout their life. And then, they'd had certain struggles, whether it was in school or work or at home. And then suddenly they would get their diagnosis as an adult, and it made sense to them why they had felt the way they did.
Yeah, you're absolutely right.
That kind of proves to me, even without everything else, that proves to me that it is a real thing, because you only need to search ADHD adult on a Twitter or something like that, and you'll come across 10s, 20s, 30s, hundreds of people saying similar. But there is a stigma still out there to mental health, and I think there's certainly a stigma in terms with ADHD. Like, what are some of the worst stigmas that you've come across in your time as a medical professional as pertains to ADHD?
I think, unfortunately, sometimes we have to fight the stigma from within the services as well, isn't it? Because whilst perhaps the CAM services and specialist ADHD services have got a lot of experience, and they've treated hundreds, if not thousands, of patients and seen some amazing results. Sometimes in other areas, people might not have noticed that, so their understanding is a little bit. I mean, our Royal College of Psychiatrists, where we all have to, refer to our training and undertake sort of exams, is very keen for all the junior doctors to have at least 6 months of experience with child and adolescent side, so that they get exposed to the treatment. And I remember my days, I'm going back a few years, when I was working in CAMS as a junior doctor. My consultant was amazing, and he said, just go and observe this child in the classroom. So I had to take permission, and I was sitting in a quietly corner, just making some notes and educating them, seeing them in different settings, seeing the response can make a huge difference in our own understanding, because a lot of sometimes people come into the profession, they think, because they've all heard about it, oh, it's just a naughty child, or everybody can get benefit from stimulants, and it's not the case. I mean, again, there is I personally think that there's a huge area where we need to invest and bring in more resources, and ultimately it will be a lot of saving for the government, because we will prevent these people from failing in different jobs, getting involved in crime. I mean, if you go to a prison population, I think probably 50-60% of the people, if you deliver a solid, well-validated ADHD tool, will probably come out on the ADHD spectrum as well. And maybe if we were to change the strategy and engage with them and give them support and treatment, who knows, even if you can reduce 10% of that, that's a huge I think is the investment will actually give you more savings because
Yeah, it is.
you reduce crimes, you will reduce you'll get more people into work, you'll get better education for these kids, relationships will be improved. So I think at the moment we are the way things are. I think things are quite stretched, in the forefront, generally in mental health. So often, what also happens that sometimes we get this views from acute services that we are having to deal with people who are really acutely psychotic or suicidal and at a very high risk. So our energies are going there, and perhaps the focus is sort of shifting away from more of these sort of conditions where people are ticking along, sometimes not maybe at their optimum level, but the resources get sort of shifted towards more acute services. But I think my view would be that we also have to look at preventative and more kind of long-term view, because if we can sometimes prevent these things from going into crisis and treating them at an earlier stages, I think it's a win-win for everybody.
Oh, yeah, absolutely. If you can
Why lead them to a place where they go into crisis? I think why not we engage them better? But I think that will need a huge amount of resources. I think we are. I think what we are noticing is we are stretched. I mean, we are a very small firm and we are working quite hard. But we are getting about sort of 50 referrals a month.
It's a lot, isn't it?
So, and there are various strategies in which you can develop more efficiencies, and sometimes you can give them engage on the telephone, give them some of the rating scales to school and other children, and maybe find some ways around it to bring the diagnostic process a little bit more efficient, so that the treatment can start early. But it is challenging. Yeah, it is challenging.
Oh, I can only imagine. I guess the more people you can catch early and get that support and treatment in early, meaning that they're able to navigate their relationship with their carer or their parents, their relationship with their peers at school, their lessons, their education. Suddenly, if they've got that support, then you're hoping that they can take that into their adult life.
Yeah.
Whereas someone with ADHD who's undiagnosed, they're going to make impulsive decisions all the way through their life. They might be a bit almost scattergun in lacking organization, being impulsive, hyperactive, and that's very difficult to manage.
Self-esteem gets very affected because they often start and blame themselves that maybe because they've had all this sort of criticism all along from the teacher, maybe potentially from other pupils, and potentially from parents that you're naughty, you're not doing the right thing, and I think that also can be. People can develop sort of learn helplessness around it, that they think I'm perhaps not good enough, and they always compare themselves to others, and then that is a very negative frame of mind they get into when potentially actually with the right support and treatment that could be altered at a very early stage, so it gives them a much more better belief about their abilities and self-awareness of it, and managing the condition better.
So one aspect I'm quite interested in is because I've got 3 children. My oldest has ADHD, youngest we're sort of not sure, but quite often I've been reading forums and things like this, you can have that the siblings who haven't got ADHD can feel a bit resentful or neglected because of the amount of attention that the ADHD child gets or needs. This can, obviously cause a bit of resentment or arguments. Parents feel guilty over the amount of attention that they've got to give to, the child with ADHD. Obviously, this is not a, that they want to give one child more attention than the other. It's just circumstance, unfortunately. But what would you say to those parents? What could they do to, navigate that minefield, if you like, of obviously dealing with, multiple children, should we say, where one or two's got ADHD and the others haven't?
Yeah, I think it's a very delicate balance, isn't it? And I think there is no right or wrong answer here. I think perhaps my approach would be to spend some time with the person with the child who does not have ADHD as well, and I think also have some strategy to sort of make sure that they get a one-to-one time where you can explain to them the condition of the other sibling, how it affects them, educating them, and using them as a partner in all global kind of way of a family unit, really. And also, I think rewarding this sibling for understanding and giving them the amount of time, because I think ultimately they will feel resentful that they are not getting that time and the other is taking it away. So I think making sure that they have that block of time as well, and educating them and trying to bring them into partnership may work. But I think it really kind of depends on an individual family. But and sometimes in some areas the family therapy can be a really good way of dealing with it. Sometimes a few sessions of family therapy, having somebody, a professional who knows how to kind of deal with those sort of conflicts in a family and bringing it out on the open can also be quite helpful, particularly for families where they are quite high expressed emotions and things are reaching a stage where the environment of the family is tense and emotionally quite charged. That's where more specialist help can also be sought. Whether it will be available at the drop of a hat, that I can't promise, but I think ideally family therapy, behavioral family therapies, and spending time with the other sibling and helping them understanding their own needs and frustrations can sometimes make a huge difference.
Yeah, absolutely. I completely agree. And I think one of the big things we tried to do is to educate the other two kids and explain to them why he can't sometimes control himself, or why he can't.
Very good job there, yes.
It is difficult. I have to admit, it's every day is a different challenge in terms of managing it, and it's not always easy. So we've obviously covered various bits, and we've covered different aspects of it. Just one last question I wanted to ask you on ADHD before we quickly have a little bit on bipolar was, in your opinion, what if for parents who perhaps they don't want to give their children medication, straight away or at the moment, for varying reasons, what would you say are the most effective ways to treat ADHD away from medication?
Yeah, I mean, behavioral strategies can be quite useful. Social skills training, putting some sort of structures around it, rewarding the right behavior, and educating them about some of the potential problems which are causing them effect can be helpful. Again, medication, I've covered a lot of this sort of. Some people just don't like taking the medication. Some children don't like taking the medication because they have some side effects. Occasionally they notice their appetite is not very good, or they might feel a little bit slowed down. So often the way I approach is that, we say, these drugs maybe don't have to be taken on a daily basis. Maybe use them on some days where you feel that you are more likely to be in a pressure situation, you have to perform in school, and tailor them around it. And I think occasionally the stigma and kind of this sort of negative perception can improve that way, and saying that it's okay to not take it over the weekend, but maybe on the school days might help for you. And I think so. There's various ways around it, and more often than not, I think people will engage.
Yeah.
But there's some more sort of severe end. I think even for the psychological therapies to be effective, sometimes the people have to engage in them. And I think that if the ADHD symptoms are so severe that they can't even sit still in a session for more than 4 minutes, and then
Yeah.
you're getting distracted,
difficult.
it gets quite difficult for putting those approaches into practice. So yeah, so I think it's a balance. But the good thing is that these drugs are not addictive. They are generally safe if carefully monitored. You don't have to go a high dose. You could start with slow dosage and use them in short bursts or periods, and give them some holidays from the drugs as well. And often people find that approach more accepting.
Yeah. Yeah.
Mhm.
Yeah. Thank you. I find that really interesting, because obviously, like I explained before, I was completely not. I just didn't think that he had ADHD. I thought it was like a made up thing. And then once he was diagnosed with it, and I was a bit more educated about it, I was quite against. I don't want him taking medication. And obviously I came around to that, and seeing the difference now, I sometimes get upset with myself for being so ignorant, because I think of the years that he missed out on having the support that he needed, perhaps because I was a bit stubborn. So in the future, I'm planning on doing, as part of our mental health series, a show on bipolar. So I'm going to try not to keep you too long, but I was wondering if you'd be able to just explain to me, basically what bipolar is as a disorder.
Yeah, bipolar is actually it's one of my kind of specialist area where because I was sort of and I'm sure my dad is quite open about it. I came into psychiatry because my father had type 1 bipolar, and from a young age I sort of saw the signs and symptoms of bipolar, and I think that in a way motivated me to be a psychiatrist. And I took medicine purely because I always wanted to be a psychiatrist. So I think it is a topic quite close to my heart as well. Bipolar is technically, from a clinical point of view, if I describe it, is a mood disorder. Most times people's mood can be sort of stable, but occasionally they can go and become depressed. So I think those conditions can be called as depressive disorders or depression. But in bipolar, people might have some periods of depression, but then sometimes their mood can become a little bit out of character and go the other way, which means that they can come across as quite elated in mood, more kind of opinionated, maybe slightly grandiose. They have a lot more energy. They feel that they could, sometimes their sex drive or libido can change quite a lot. They make impulsive decisions, and that can be quite devastating for a lot of people. And then they might have that period for some period of time, for weeks, sometimes days, and then they might go normal again, and they might get depressed again. So I think sometimes they find it very hard to even know where they are in their own life, because they don't know what person they are. One day they are waking up and they've got lots of energy. Some weeks they're waking up and they just can't have anything to do. They feel withdrawn, suicidal. It's again the from the point of view of the long-term outcomes of bipolar is quite a severe condition, that 20%, and it's a very sad statistics actually, that 20% of the people with bipolar disorder actually end up committing suicide, and nearly 50% of them would have self-harmed or had some ways in which they would have tried to take their life or might have been saved, but some unfortunately are not that lucky. So it is a very, very um, uh, um, condition which needs a lot of time, and I think the way I see it, I usually take a journey with that patient, and it could take sometimes months, sometimes years to get it right. So yeah, that's in a nutshell what bipolar is. It is a spectrum. So some people tend to get more milder version of it, where they would have what we call them as a hypomania, which is that they might get more increasingly more sociable. They might have more energy. They can be quite productive in that time, but they can be impulsive, and they might do some things which are a bit out of character. That is perhaps just about not as severe, and they could be treated at home with some changes in medication, but and that is called the type 2 bipolar disorder. And then there's a more severe form of the bipolar disorder, which is called type 1, where people actually get manic. So in those sort of phases, they could start to have some delusions or even hallucinations. They might think they have superpower, or they Jesus Christ, or they just would not sleep. Usually those individuals would have been picked up by the psychiatric services, unfortunately often sectioned in a hospital and needing long periods of stay or stabilization. And it is a remitting and relapsing condition. So I think more often than not, if you've got that condition, that stays with you for life. But it is treatable, and a lot of people can still have a very fulfilling life with the right treatments. But it is a big topic, So I'm just only going to touch base a little bit on the sort of introduction of it.
Yeah, of course. And like I say, I'm going to definitely be doing a show on bipolar.
Yeah.
But
I'd love to be a part of that.
those
Yeah, because I think it's,
those
and I think before you go, I think I
yeah.
may to point out that bipolar.
Oh no. Oh, we've lost Dr. Mo.
Type 2 or bipolar as well, and 50%. Okay, can you?
Oh, yeah, you're back now. You just went for a
No, yeah,
split
I think the
second.
voice. So I was just saying that even with ADHD and bipolar, there's a lot of comorbidity. So about 20% of the people with ADHD could have bipolar as well, and about 50% of the people who have bipolar could have ADHD. So there's a lot of links there as well, which we can talk about in the future, because that's quite a big area, and I think that's an area of my research. I'm presenting some data to some conferences as well, so I'll be quite happy to share that with you at some other point. Yeah.
Yeah, that'd be
For your
fantastic. I'd love to get you back on to speak about bipolar in detail, because like I say, I'm not massively familiar with it, but just those statistics alone,
Mm.
About like the amount of people which harm themselves
And
and
suicide
kill
particularly.
themselves, I find that incredible, and it's distressing. That's an amazing amount of people who they just I find that really shocking. I got to be honest.
Yeah,
But
yeah,
yeah,
and that's just unfortunate sort of data. Mm.
yeah. So like I say, we'll definitely get you back on to go into that into a bit more detail. Um, I just want to thank you anyway, Dr. Mo, for coming on. I really appreciate you finding the time. Obviously, you're a very busy man, so I appreciate you finding an hour for me.
No, it's a mental health awareness week next week, and this is just a little bit of my time to sort of support you and your viewers, and I think it's for me as well. It's important that I keep educating people as well. It's apart from treatment, I think education is and working together with all of you, I think that is going to be the key in terms of future strategy development for even Department of Health. Really, I think the more understanding there is on all levels, the better the treatments will and availability will become, hopefully. Yeah, and that's my goal.
Yeah, I hope so. And like I say, it's Mental Health Awareness Week next week. You can find Dr. Mohamad on Twitter at Mohamad_Wasi. WASI, and you can visit mental health and wellbeing website for advice and services at www.mentalhealthandwellbeing.co.uk. You can find me on Twitter at acecast_nation. Plus, we're on Facebook and YouTube under Ace Podcast Nation, where you can subscribe to support our ongoing shows on mental health and other subjects. Thank you again to Dr. Mo, and thank you to everyone who's watching, and I'll see you again soon.